The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Vanderwall.
Present.
Representatives Thompson.
Present.
Mearman.
Here.
Tisdall.
Here.
Bierlein.
Here.
DeBoer.
Here.
Preston.
Here.
Schmaltz.
Here.
St. Germain.
Here.
Bonac. Frisbee.
Present.
Whitsitt. Carter.
Here.
Whitworth. Neely.
Here.
Hoskins. Foreman.
Here.
Mr. Chair, you have 13 members present. You do have a quorum.
Thank you, Madam Clerk. Representative Carter moves to adopt the minutes of the February 26th meeting. There being no objection, the motion passes. Today we are going to be hearing testimony on House Bills 4077 and 4078. We also be finishing up our discussion from last week regarding the 340B program by hearing from Michigan Primary Care Association as well as Michigan Rare Coalition. We also have in the audience the Michigan Health and Hospital Association and Pharma, available for questions if there's still questions regarding their presentation from last week. First up, we will hear testimony on House Bill 4077 and 4078. We are joined by Representative Rogers and Representative Mueller here to discuss their bills, as well as Jared Rozicki from the Michigan Funeral Directors, as well as Sarah Jensen-Votter from Palmer Jensen Bush Funeral Homes. They are all joined by Dr. Carl Hawkins with the Michigan Association of Medical Examiners. Representatives, if you would come on up, and you've already done that. The testimony table is yours, and we look forward to your explanation on the bills.
Thank you, Chair Vanderwall, Vice Chair Thompson, and committee members. Representative Mueller and I are here to give testimony on House Bills 4077 and 78. Together, the bills require timely certification of death certificates by physicians through the Electronic Death Registration System, or ERDS, a web-based system used by the Michigan Department of Health and Human Services, and clarifies when the certification is to be conducted by a county medical examiner. These bills are reintroductions from last year. House Bills 4077 and 78 passed unanimously out of the House Health Policy Committee, passed with wide bipartisan support in the full House, and ran out of time in lame duck in the Senate. The intent behind these bills is to modernize the medical certification of death certificates and to address a significant frustration facing grieving families in Michigan, which is how long it can take to obtain medical certification on death certificates. Under current statute, both a licensed physician and a funeral director are required to complete a medical certification of death. A physician is required to complete their portion within 48 hours of being presented, and failure to comply is a misdemeanor. However, many certificates of death are filled out physically and then faxed to a funeral director to be uploaded into the ERDS system. This can result in significant delays for families receiving death certificates, which are necessary to deal with insurance, proceed with burial or cremation, and settle legal affairs. These delays may sound minor, but can put an added strain on families when they are already suffering the loss of a loved one. My bill, House Bill 4077, requires physicians to enter the cause of death determination in the medical certification of death into the ERDS system. It also requires physicians to certify death records and replaces the misdemeanor penalty for failure to comply with medical license sanctions. Developed in consultation with MDHHS, the Michigan Funeral Directors Association, MSMS, and other stakeholders, there is widespread support for these bills. During the onset of COVID-19, many of us also saw a backlog of death certificates as we saw the tragedy of many deaths and delays in the system because of the volume. Like other things, it exposed an issue in our system that needs to be addressed. Additionally, I have heard from county clerks who administer vital records that the slowness with signatures on death certificates can lead to delays in processing of other things for families. Now I'm going to turn it over to Representative Mueller to discuss his bill, House Bill 4078. Thank you for your time and consideration.
Thank you, Mr. Chair. Representative Rogers did a pretty good summary of basically the whole package. However, my bill specifically deals with time frame. The current law is that when someone passes away, they have to, individual dies without a medical attendance by a physician with 48 hours. What this bill does is basically switch it from 48 hours up to a year. So if someone dies unexpectedly from violence, unexpected or a suspicious death, the medical examiner is usually the one that has to sign off on the death certificate. But if you see a physician within 48 hours, they're supposed to do it. Well, this is causing some ambiguity, like Rep. Rogers said, and delays with certifying the death, which puts people that are already mourning more frustrated because they can't have the burial, and then it does affect some religious views about timeliness of when you can be buried. So basically all my bill does is make it so if they've seen their primary care physician within a year, the ME is still going to do the certification. And if there's any other questions, we do have, like you said, we have the people that are experts on this to give their explanation.
Very good. I appreciate any questions from the committee. I think that yes, we do. Representative Carter.
Thank you, Mr. Chair. Let me cut this on. Thank you, Mr. Chair. Are there any concerns about additional burdens or medical examiners due to these changes?
My understanding, again, in working with MSMS, who represents a large portion of physicians in the state, is that they're supportive of these changes.
Thank you.
Any other questions? I think that I've got a couple, but I'll save them for when the next group gets up. Thank you, representatives. I appreciate it. At this time, if the next folks that want to come up, we have Jared Rozicki and Sarah Jensen Vader, and Carl will catch you on the next round. How's that? Very good. Testimony table is yours, and thank you for being here today.
Thank you. Thank you, Chair Vanderwall and members of the House Health Policy Committee. My name's Jared Rozicki. I'm the Director of Government Relations for the Michigan Funeral Directors Association. With me today is Sarah Jensen Vader. She is a funeral director and owns and manages Palmer Jensen Bush Funeral Homes here in Lansing, just down the road. On behalf of 1,100 licensed funeral directors and over 400 funeral homes, we are happy to be here speaking in strong support of House Bills 4077 and 4078. I believe Representatives Mueller and Rogers did a really good job covering the bills, so if I may, I'd actually like to turn it over to Sarah, and she can kind of go through the rundown of how this issue impacts her every day at her funeral home.
Thank you, Chair Vanderwall, and all of the committee members for seeing me again today. As Jared said, my name is Sarah Jensen Vader. I own and operate Palmer Bush and Jensen, actually just a stone's throw down the road here. And we are lucky and blessed enough to be trusted with about 400 grieving families a year here in the greater Lansing area. When someone dies, no matter who they are, no matter where they die, no matter how they die, a medical certificate of death has to be filed by a mortuary science licensee. Upon receiving a death call, just so you guys kind of understand my everyday life, there's what we call first call information. There is the name of the deceased, kind of important. There's where they are, their next of kin, the phone number to contact the next of kin. And then there's always the questionable part that we have to ask and kind of dig into, and that's who's going to sign the medical certificate of death. This right is usually given to a hospice physician if they're the ones that just admitted them, a family physician if there wasn't, or eventually it goes back to our medical examiner's office. Signing a patient's medical certificate of death is the final act of service that a physician does for their patients. If House Bill 4077 and 4078 were enacted, it would make the process simpler, more efficient, and less burdensome for the physicians, myself as a funeral director, our county clerks, and more importantly, the grieving families that we all serve in our communities. As I was preparing for today, and as I have in the past, I was reviewing a logbook that we keep. It kind of tracks the completion of the death certificate process when someone passes till the point that it's certified with the state of Michigan. Of the hundreds of doctors and physicians that we have signed death certificates in the greater Lansing area, I have 12 that utilize EDRS. If one of those few medical certifiers is the one that I know is going to sign for a family, I can breathe. I know that family will have zero delay in planning their services. We'll have that back within the 24 to 48 hours. I know these families, and it hurts them to not be able to move forward with planning and going forth with their arrangements because they're waiting on a signature. When our funeral home has a physician that doesn't use electronic death registry system, they get a hard copy, and this is faxed to them. So there's kind of 4 situations that we see most of the time. The first one is we throw up a prayer, praying that the doctor's in that office today, because a lot of times doctors work from home. They have multiple branches that they visit. A lot of them are on call at the hospitals. Secondly, we have the signed medical certificate of death, and then we pray we get it back, because it ends up on a desk in a to-do pile to get faxed back to us. The hardest part is when the physician fills out these electronic certificates of death, and what happens is they miss a box. So if they use the electronic death registry system, it wouldn't let them move forward without everything being completed the way it has to be. The final one is kind of a personal favorite, because we get a good chuckle every day, is we get the faxed medical certificate back, and all of us get to try to decipher what it says as the cause of death. When we receive a hand-signed medical certificate back, our office then physically inputs the information into the electronic death registry system. We upload the actual scanned document so that the local clerk's office can then verify that the doctor is the one that came up with the cause of death and then is the one that actually signed it. So then on their end of things, the county clerk's office turns around and they have to look at the electronic death certificate that we sent them. They have to verify that every letter is the same, every interval is the same, and essentially it means we're doing the job twice and then they're doing the job twice. With the hard copy medical certificates of death, it allows for more errors. It is more work on the county officers, and it's longer waiting periods for the families. When a physician utilizes EDRS, as they would with these bills, they simply log in from wherever they are. They fill in the boxes. It doesn't let them go forward unless they fill in all the correct boxes. And then it's saved and ready for myself and other funeral directors to grab it from the cloud. When families are forced to wait, it causes all sorts of issues. We have families where it goes against the core beliefs and values. Those of the Hindu faith prefer to have their loved ones cremated. They can't be cremated without a signed death certificate. For them, that should be within 24 to 48 hours. That is not the norm. Members of the Jewish faith have beliefs in being buried within 48 hours. We even have families that can't fathom the idea of planning funeral arrangements until they have a death certificate so that they can access the funds to pay for it. Once again, nothing can happen without a signed medical certificate of death. I can tell you one of the most frustrating parts of my profession is having to delay a family's request because I don't have a signature. When you lose someone, there's millions of memories going through your mind. The signing of the death certificate should not be allowed to be or impact the ability to celebrate those memories. Without your support of House Bill 4077 and 4078, these hard copy medical certificates will continue to be the norm. They will continue to allow for more errors, more work on your county clerks, more work on your very tired funeral directors, and longer waiting time for the grieving families in your communities. I ask on behalf of the families and the community that I serve for your support of House Bill 4077 and 4078 to lighten the burden of the grief on our families. Thank you.
Thank both of you for being here. Committee, any questions? Representative Carter.
Of course, you know I'm grateful.
Yeah.
Okay. But you mentioned that most physicians do not use the electronic death registry system. Can you explain to us why?
In honesty, I think it may just be a instance where they need to be trained on how to use it. Mm-hmm.
Representative Foreman.
Thank you so much. My family works in the funeral industry, so this does impact my family's day-to-day life, and I understand your frustration, so thank you so much for the work that you do. My question piggybacks off of Representative Carter's. If physicians are not using this and it is a matter of training, who can offer that training? Is it departmental? Who would it fall on, and how can we get physicians up to speed to be able to use EDRS efficiently?
Yep, so that would be the Department of Health and Human Services that would provide that training. They're currently working on EDRS 2.0 because obviously some of the reasoning why physicians aren't using the current system is it's not as user-friendly as it could be. The department anticipates that will be up and running by July of this year.
Great. Any other questions? I have a couple, just your mind kind of works through. How many cases or individuals that pass away are we waiting to hear back from a doctor? And I mean, how long, what's worst case scenario?
Yep. So glad you asked that. I just got some statistics back yesterday from the Vital Records Division at DHHS. Over the past 5 years, 75% of all death certificates were not medically certified within the 48 hours that's statutorily required.
75%.
75% are delayed. Yep.
So is your example in folks that in their religious beliefs that, I mean, what is that? I mean, I guess my question is, how do we handle that currently? Do we just push off their funeral or their cremation?
Mm-hmm. Correct. We can't move forward.
Okay. Very interesting. Any other? Yes. Representative DeBoer.
How do we know that the electronic signature is from the doctor?
So currently with the doctors and physicians that we have that do sign electronically, they have forms filed with, I believe the department is, I just filled a form out yesterday, I can't remember. You pre-sign and pre-register with them so that everything matches perfectly. And then when you log into the system, they have a authentication where you can email it, text it, so that the only person that can log in under your name is a direct contact to you.
Okay, thank you.
Seeing no other questions, thank you both for being here. I really do appreciate it. And with that, Carl W. Hawkins, MD. Welcome to the testimony table, and whenever you're ready, if you push the little button and the light will go red, the floor is yours.
Thank you, Chair Vanderwall and members of the Health Committee. Am I close enough? I'm sorry.
You are.
My hearing is not up to par. Okay. All right. My name is Carl W. Hawkins. I'm a medical doctor, and I'm the excuse me, the immediate past president of the Michigan Association of Medical Examiners. I'm actually a board-certified family physician, and I practiced in St. Ignace for 33 years, retiring from that several years ago. I graduated from Michigan State University College of Human Medicine, completed family practice medicine residency training at Hennepin County Medical Center in Minneapolis. All this gives me a fairly broad perspective on these House bills, as I'll briefly explain this momentarily. I became involved with the medical examiner work as the county I was practicing in needed help with this, and I obliged. I found it interesting and a significant service, and I stayed involved. I've been the chief medical examiner in Mackinac and Emmett counties for about 35 and 27 years, respectively. In the less populated counties, primary care physicians often provide the medical examiner services, getting consultative and autopsy help from the forensic pathologists and their services as needed. Our organization has forensic pathologists, primary care doctors like me, and many medical examiner investigators as members. I was chosen president not because I know any more than anyone else, but in hopes that I could keep things moving. Our organization, the Michigan Association of Medical Examiners, supports House Bill 4077 and 4078. Currently, medical examiner offices are somewhat overwhelmed with having to certify and sign death certificates for death cases that really do not need to be done by them. In a nutshell, medical examiners need to certify non-natural deaths and unexplained, unexpected deaths. And we believe that attending physicians who have known their patients over some time before death often can most appropriately and accurately certify deaths by signing these death certificates. This has been the standard over the years, but often the medical examiners wind up being the certifying physicians even when a decedent is known to an attending physician and the ME office has determined that no further investigation is necessary and the manner of death is natural. We believe these bills will make death certification less burdensome for the medical examiner's services. Now, this can get difficult, as an attending physician may not have had significant contact with the patient before that patient's death, and there may be times that an attending physician may rightfully not be confident in certifying his or her patient's death. In such a situation, medical examiner involvement would be appropriate. While this scenario does come up, we believe that these occurrences would be far outweighed by the number of deaths that attending physicians could appropriately certify, thus reducing a large burden the medical examiner offices, in particularly the large offices in the state, currently deal with. Having practiced family medicine for many years, I believe I have a pretty good perspective on this problem, understanding the difficulties death certification can present to physicians in very difficult and busy clinical practice or in medical examiner office. And I agree with our organization's support of these House bills. I would be happy to field any questions actually from the perspective of the medical examiners or the perspective of practicing physicians.
Any questions from the committee? I have one question, and I mean, how many cases does a normal director or examiner have to throughout the state? I mean, it's a strange question, but
No,
if it's
that's-
overwhelming folks, how many do we have?
How many medical examiners?
Right.
Okay, that's actually an interesting problem. The medical examiner system is county-based by statute, so every county has to have a medical examiner and has to appoint a medical examiner. And in the past, it was it had to be a resident of the county or someone in an adjacent county. That got changed big time. It's probably been 25 years now. And with the electronics, it became very appropriate for a medical examiner system to cover counties across the state, geographically a long ways away. And it does work. So consequently, the services have been more and more, what's the right word, consolidated, often by with the bigger offices. So as far as the number of medical examiners out there practicing is probably like 60 or 70, somewhere in that range. But that's really a guess, so I don't really have that number. Of course, like many organizations, all medical examiners are not required to belong to our organization, of course. And as far as how many cases and that a medical examiner handles, it varies completely by location. Okay. I'm in small counties. I certify about 150 to 160 cases per year. and that's like a weekend for the, well, maybe I'm exaggerating, but for the bigger offices.
Very good, thank you. Rep. Thompson.
Thank you, Mr. Chair. Could you explain to my colleagues and the members of this committee the differences between when a medical examiner is signing a certificate of death due to a murder, homicide, a motorcycle accident, any type of accident within the county versus a physician that is signing, or a hospice physician that's signing for someone that is on hospice, where they know they're going to pass, and then they're contacted and they sign that death certificate, or someone that dies at home, someone that's dying in a facility or a hospital. Can you kind of break down a little bit so that they may understand, if they're not in this world, on how these death certificates are signed, and what the holdup is for someone not wanting to sign because maybe they haven't seen or cared for the patient in a little bit of a time frame?
Thank you. That's that's a very pertinent question and issues. The natural deaths that are reasonably explained and not necessarily expected, but reasonably explained, can be signed by attending physicians or medical examiners, generally depending on somewhat of availability, because some people don't have doctors. Okay, but it can be signed by the doctors that are familiar with them. And that works quite well. In someone that's been in hospice, that is well established and well attended, there generally isn't a big issue, except just bogging down in the system where certificates are requested and people are busy and that kind of thing. And those should be able to be handled quite quickly. There are delays that sometimes are inevitable, people on vacation, and where the covering physicians might not truly know the patient. Those things can happen, but that's the minority. Most of the problems we really believe are manageable and shouldn't happen. Now, when things are more complicated and not natural, homicides are obviously the most obvious of complicated. Those can be very difficult and they can take a long time because they have to be investigated thoroughly, and other things like drug overdoses, other toxicological problems, even bad accidents, motorcycle accidents, snowmobile accidents, suicides, gunshot deaths that are not homicide, gunshot deaths that are accidents. Those things take a lot of time to investigate. And no, we aren't able to crank out a final death certificate in 48 hours. If we did that, we'd be really careless. However, what we do is we crank out, I shouldn't talk like that. What we do is generate with the funeral home a death certificate with really as fast as we can reasonably do it, and that often can be done within 48 hours. But we use pending further investigation as the cause of death, and pending investigation as the manner of death, and that offers a certificate that can be is pretty good for most things. It's not very helpful to life insurance companies, but it generally is helpful for things like landlords and bank accounts and car dealers, and I'm sure that our very experienced funeral director probably can answer that part of it more carefully, more better than I can. Does that answer? Does that help, or is there more that you
Yes.
need?
Well, is it safe to say then that a medical examiner should be signing the certificates for anything other than a natural death or more of the traumatic deaths, and that our physicians, we need to set up a system so that they're able to promptly sign the death certificate for patients that are dying of natural causes or that have been under the care of a physician within a year or two. That's kind of the difference that I was looking, and you did a great job of explaining that on whose
Okay,
responsibility
that actually
it
needs a
is.
little more comment, I'm sorry.
Okay.
That's a non-natural death by statute, by law, it has to be done by the medical examiner. Okay, and an unexpected natural death that's really not explained and not readily figured out, that should go to the medical examiner. And the ones that should be going to the physicians in practice are the ones that are more readily figured out and certified. And the medical examiner also is responsible for people that are unattached, and that happens a lot, or people that are visiting and they're and the doctors sometimes are really not available across the country or even out of the country. It can be kind of tough. But in general, yes, natural deaths that are easy to explain should be done by the attending physicians, and anything unnatural by the medical examiners, and that's actually by statute.
You did an excellent job.
Well, thanks for asking that one. That comes up frequently.
Thank you.
In
Any
a lot
other
of
questions
contexts.
from the committee? Seeing no other questions, thank you for your time.
Well, you're very welcome. Thank you very much. And thank you, the whole committee.
All right, I have a couple cards to read in. Charlie Burden, Department of Health and Human Services, not wishing to speak, supporting the bill. Kate Dorsey, Michigan State Medical Society, not wishing to speak in support of the bill. Thank you. Next, we'll hear, we're going to move on, and next we're going to hear testimony from Frank Waters with the Michigan Primary Care Association. We have other folks that are going to join you. All right, excellent. Whenever you guys are ready, just remember to press that red button, and the testimony table is yours. And we look forward to your presentation. Thank you.
Thank you, Mr. Chair. We greatly appreciate this opportunity to talk about the 340B prescription drug program. I'm Frank Waters with the Michigan Primary Care Association, joined by Mike Weeses of Hackley Community Care, Kelly Pardee, and Matt O'Brien of the Great Lakes Bay Health Centers. I'm first going to kind of set the table I represent Michigan Primary Care Associations, which represents all the federally qualified health centers in the state. So just want to talk about who they are, and then have the health centers talk about the 340B program, its effect on their patients, and some of the challenges that they're facing. First, there are 41 health centers in the state of Michigan with 400 locations, serving close to 700,000 Michigan residents. We're required to be in underserved areas and serve underserved populations. And we offer primary care, with many offering services like dental, behavioral health, and vision. Our patient populations on average across the state is 50 to 60% Medicaid. And so it's a huge issue at the federal level that we're keeping our eye on. So there's a lot of factors that are sort of converging on health centers currently that really put into question the care that they're able to provide. And the last thing I want to mention related to the health centers is that they're required, and it's their mission, to serve patients regardless of insurance status. So if anybody shows up, they're going to receive care at a federally qualified health center. As it relates to the 340B program, health centers are committed to transparency. They have federal reporting requirements, and every health center can tell you where every single penny of the 340B program savings goes. So some of the things that they use them for are transportation, for services that they just don't receive enough in reimbursement, like dental and OB, and of course, discounted prescriptions. And every dollar stays in the community from the 340B savings program. Every dollar goes back into patient care in the communities that they serve. And so with that, I want to turn it over to start with Mike to talk about the situation at Hackley Community Care.
Thank you, Frank. Thank you, Chair Vanderwall. Thank you, members of the committee. My name is Michael Weeses. I'm the CEO for Hackley Community Care Center in Muskegon. We were founded in 1992, main operations in Muskegon Heights in the city of Muskegon. We serve approximately 23,000 patients in 26 locations throughout the county, 4 primary care locations where we also provide dental services, pharmacy, and mental health services. We also operate 2 teen adolescent health centers in Muskegon County and 18 E3 sites which offer mental health services in schools in Muskegon County. We currently have 1 in-house pharmacy, but we have 20 contract pharmacies. I'm sure you've heard that lingo already. Hackley Community Care averages about 100,000 visits annually through our medical, dental, and mental health departments, with over 70% of our patients enrolled in Medicaid and or Medicare. We have approximately 325 employees in Muskegon County. Just to give you a little background on 340B, it is organized by the federal government but not paid for using tax dollars, either state or federal. How do we use these 340B funds? In 2024, Hackley Community Care medical and dental operations, so our medical department and our dental department, experienced an operating loss of $2.6 million. The savings that Hackley Community Care received through the 340B program helped support our operational losses and allowed us to continue to support our vulnerable population. In 2024, our federally qualified health center provided an estimated $1 million of medication assistance through our sliding fee program. Hackley Community Care experienced an operating loss this past year, 2024, of $1.3 million, mostly attributed to manufacturer restrictions. And this represents a $3 million negative change from 2023. We receive manufacturer restrictions almost weekly, sometimes daily. And we actually have allotted 3 full-time employees just to monitor the 340B program for these incoming restrictions. And if we don't act on them expeditiously, then we risk losing those funds. So what is the impact if there's no action? We will be faced with staffing reductions similar to other FQHCs throughout the country. We're going to have to either reduce or eliminate our mobile unit services, which we offer mobile medical and dental services in our community due to the low volume and higher costs. Outreach in our community will be reduced significantly. The state did approve us last year to explore a new facility in Muskegon Heights, which is an economically disadvantaged area, and those plans may be delayed or eliminated. And also the reduction of non-reimbursable services that we currently provide by our medical department, which includes community health workers and our clinical care teams, would be affected. In closing, health centers can't account for every dollar, as Frank mentioned, that comes from our 340B program, and it all goes back into patient care, which is a federal requirement for our health centers. And health centers are very transparent with our relationship to the 340B program. I know there's some legislation pending or action taken presumptively on the federal government side, but the impact is too great to wait for the federal government to come up with a solution. I would like to thank Chair Vanderwall and the committee for your consideration and support of Michigan Health Centers.
Thank you, Mike. Thank you, Chair Vanderwall and committee members, for allowing us the time to tell you about the importance of the 340B program to our communities. As Mike said, the 340B program is a non-tax funded program essential to health centers across the state. Great Lakes Bay Health Centers is one of 41 health centers in Michigan that provide quality health care. We provided 244,000 visits last year to 56,000 patients across 16 counties. Because of the 340B program, we are able to stretch scarce federal resources, reaching more eligible patients and providing more comprehensive services that we would not have otherwise been able to, therefore increasing access to care. I work daily in and around our 4 pharmacies that we have at Great Lakes Bay, and there's stories that happen every day. Transportation is a huge issue. Great Lakes Bay provided almost 24,000 rides to doctor's appointments last year. Due to some of the contract pharmacy restrictions, in part, we stopped providing transportation in both Huron and Lapeer counties in early 2024. We also have a sliding fee discount and low-cost medications to those patients who qualify. Our program allows those patients to get that med when they leave the doctor's office, helping them remain more compliant. We also offer free delivery to our patients. So we have 2 delivery drivers that are delivering about 800 meds per month in the Saginaw and Bay City areas. A lot of these patients, you go to the doctor 2, 3, 4 times a year, but your medications need to be refilled each month. And those patients are always looking forward to seeing our delivery drivers each month. Most of our clinics have a community health worker embedded in the clinic that is helping patients with a variety of issues as far as housing, food, signing up for insurance, finding transportation. They are vital to our interdisciplinary team and are not reimbursable. Next, my colleague, Kelly Pardee. She is our pharmacy business director and directly in charge of our 340B program at Great Lakes Bay Health.
Thank you, Chairman and committee members, for giving us the time to come here and talk about this important program. My role at Great Lakes Bay primarily has been to oversee the 340B program and everything that goes along with that. Recently, it's been a lot more of a challenge to do that, as Mike and my other colleagues have mentioned, with restrictions and just increasing burden to prove what it is that we're doing with the money. And we're happy to provide that transparency. I wanted to take a moment to kind of just give a little personal twist on why this program is so important. A couple of years ago, I've been at Great Lakes Bay for coming on 4 years, but within the first year of working at Great Lakes Bay, my office is located next to a care management nurse office, and I overheard a conversation with a patient that really hit home for me, that helped me to understand what makes what we do different. And so this nurse was on the phone with a patient. They're on the phone with patient all day. And I hear things like, tell me about your blood sugars that you've taken all this week. Tell me about your diet. This particular day, I heard the nurse say, what did you have to eat yesterday? How many bites of potatoes did you take? Getting down to that really personal level with the patient. And it just, I have a personal a story about a family member, actually my mom, who was a Medicaid patient, and you know, when you're a Medicaid patient, sometimes it's hard to find, harder to find care, and so it's a little easier to go in and actually be able to see the provider, but to get the comprehensive care that we're talking about here is a little more difficult. These nurses and community health workers and all these people, they provide extra care to these patients they may not get otherwise, where they don't understand what medications they're taking. They don't understand the importance of their diet. They don't understand just how sick they are. And unfortunately, my mom actually ended up passing away due to some of these things that I think contributed. She didn't realize how sick she was. She didn't realize the importance of her diet. And I work in healthcare, and I didn't realize that either. And we have these services for these patients that provide this kind of care. Federally qualified health centers get grants to help with some of this stuff. We currently do. We hope we keep getting those. But it's just a fraction of the amount of money that it costs to provide these kinds of things. And if the 340B program continues to be restricted, or you know, these funds keep getting cut, these are the kinds of things that are going to go away for those patients. And it's why what we do here is so important, and why, you know, why we're here in front of you, and why we continue to fight and offer the transparency that everyone's asking, so that you can see what it is that we're doing. So thank you for your time today.
If I could just add a couple of points just related to the eligibility of receiving the 340B savings. So the biggest issue is contract pharmacy restrictions. They are limited. Many manufacturers are limiting the health centers to one location. So when you look at Great Lakes Bay Health Centers, they're serving, I think you said 15 counties. They have to pick one physical location. And if a patient, and that's the other thing, they have to be a patient of the health center. If a patient decides to go to a different health center in their own county, then the health centers don't receive those dollars. So that's the main issue that I wanted to address, that it is, you have to be a patient, and the limitation is to one physical location. Happy to take any questions. Thank you so much for the time.
Very good. Questions from the committee? Representative Tisdale.
Thank you, Chair Vanderwall. So I'm learning more about 340B and federal programs than I ever really wanted. But it appears to me that you've got, if you go, my understanding is 340B started in 1992, something like that. EMTALA, the Emergency Medical and Treatment and Active Labor Act, was in 86. So you've got one federal action. It requires you to provide basically unreimbursed services, and then maybe you come up with 340B to help offset some of that. The problem is now, as I look at it, the pharmaceutical industry in the U.S. is about $670 billion. Testimony was given that 340B is 66. That's 10%. It's growing 22% year over year. That means it's going to double every 3.25 years. Do you see where there's a problem? And I don't suppose that, I'm not suggesting that your underserved populations are doubling every 3.25 years, but you can see where the pharmaceutical industry might be saying, hey, wait a second, we've got to get some control on this. What kind of growth do you see in that 340B program for your service? What kind of growth would you anticipate as reasonable year over year?
Thank you for that question. We've actually seen our 340B savings decrease dramatically over the last 5 years. It kind of peaked about 4 years ago, and now it's gone down probably by 50%. So I recognize your question as far as the percentage of 340B savings that are going to health centers. I can only speak for our federally qualified health center that the dollars that we use aren't going towards anything other than patient care.
And down by how much did you say?
Our 340B savings have gone down by 30 to, or actually close to 50% in the last 3 years.
In the last 3 years. While industry-wide, it's growing 22%.
And that's even with our patient population has gone from, I started with Hackley Community Care 3 years ago, and 4 years ago we were about at 17,000 or 16,000 patients, and now we're at 23,000. So we've seen an inverse reaction. I don't know if Great Lakes Bay can answer.
Ours has been very similar, yeah.
There seems to be a disconnect here.
I would say I don't have all of the answers that you're asking for. There's a lot that goes into it, but I will say that one contributing factor, a lot of times you see the growth that they talk about in the program in dollars, because that's what makes sense to most business people is dollars, right? You tend to get the most 340B dollar savings in brand name new drugs. They start out at high dollars, and the 340B discount is usually 30 to 50%. So when you have brand new therapies coming out, and we want our patients to be on the best therapies, right? So we're gonna try to get our patients on the best medications to take care of what they have. If we're getting them on those best medications, our growth in dollars is going to increase because the amount of money that we're saving is going to increase for that. You don't see it as much in federally qualified health centers because we're primarily primary care and mental health. You see it a lot more in hospitals because they're providing cancer care and all those other things. So that's why you hear us say that ours is staying flat or even decreasing, because we're not doing as much specialty care, while the hospitals are seeing a lot more because they are on the cutting edge trying to get those patients those therapies, and their dollars in savings is increasing because the cost of the drugs are increasing.
So the prices are going up rapidly, more rapidly than your underserved populations. That could be driving part or maybe a majority of the 22%. But you see, from where I'm sitting, I'm just trying to break it down in math and make it as objective as possible. There's this conflict in visions that I can't quite figure out, and that's what I'm struggling with. And I think it's probably true for the rest of the committee members as well. So thank you very much.
Any other questions from the committee? Just a couple on my end. And I understand that the majority of the drugs that they're approved federally or by the state, is that correct? The FDA. So my question is, do we have an opportunity that we use generics at all in these cases, or is it always a name brand?
That's certainly an opportunity if generics are available. When new drugs come to market, they have I think 17 years of exclusivity on that patent before generics available. I don't know that exact number, but these new drugs that Kelly was talking about do not have generics available.
All right, thank you. The next piece that was brought up, and walk me through the medical restrictions that you're seeing right now in the medicine that.
I'm going to defer that to my colleague over at Great Lakes Bay.
Okay.
So the restrictions that we're seeing are exclusively at contract pharmacies. So when our patient doesn't use our pharmacy but goes out to a partner pharmacy that in the community, whether it be an independent or a chain pharmacy, and the manufacturers are generally saying that either you cannot do that at all. There are a couple that say nope, none, and then the rest of them are typically saying you can use one. And so we have to go onto a website where we have to declare what our one pharmacy is going to be, and we are restricted to only if our patient goes to that pharmacy, we can get the 340B savings. If they go anywhere else, sorry about your luck, you don't get it. The problem with that is that our patients can generally choose where they go. Our patients always have the freedom to go wherever they want to. Their insurance company may mandate them to go to a certain pharmacy, but not us. In addition, we are required by many manufacturers to submit data of all of our claims that we're running through the program on this website, which is fine for transparency purposes, but currently I have about 10. It's less for federally qualified health centers. Hospitals have somewhere around 25 different manufacturers with all different rules, and that's not an exaggeration. Some of them want this data, some of them want that, some of them you have to do it in this time and that. So it's really burdensome to get them the information they're asking for. And if we don't provide it, then we don't get the price.
Very good, thank you. Representative Frisbee.
Thank you, Chair. For federally qualified healthcare like yourselves, if you could give me a list of 3 to 4, excuse me, thank you. If you could give me a list of 3 or 4 items that would address your biggest concerns on how to fix 340B from your perspectives, what would those be?
The main one is the removal of the limitation on contract pharmacies. It's that simple. That's the biggest issue facing health centers related to 340B. We did have an issue with pharmacy benefit managers, what we referred to as pickpocketing some of the 340B savings, but a couple of years ago, the state passed a law prohibiting that, and so that's largely been addressed. I see the chair nodding. Thank you for your help on that. And so really, it's the contract pharmacy is the issue that is the biggest challenge for health centers. It's what's preventing the majority of the 340B savings from coming to health centers.
Okay. What I heard her just say, if I can follow up, sir.
Absolutely.
Is that the reporting mechanisms are vary by every different pharma manufacturer. Is that correct?
Yes, each manufacturer has their own policy. It's posted out on this website they provided to us, and they update them often, all over the place. Yesterday I got two emails of updated policies, and it's very difficult to keep track of. So not only are the restrictions causing us to lose money, but the fact that each of these, 10 to 20 different manufacturers are making up their own rules and changing them weekly, daily, just makes it almost impossible to keep up with. And Mike mentioned how, he used to have one person basically in charge of his program, and now he has three because we're having all this extra burden put on us, and it's just difficult. Not that we are against the transparency that we're being asked to provide necessarily, but the fact that there's nothing telling them, you can only update your policy so often, or everybody has to have the same policy or anything. It's very difficult.
And that was supposed to be a federal fix, is the way I understand it. This just never happened. Those guardrails around what's required.
Yeah, there's been some federal bills introduced that just have not made it there, so the manufacturers kind of took it upon themselves to put those in place.
Thank you. Thank you.
And maybe
Thank
just
you.
to comment on the federal side of it, that's a great talking point that some in opposition use to making state changes. I've talked to our Michigan delegation in Congress, and 340B legislation isn't going anywhere in the short term. So that's why many states have taken this route of addressing the issue of contract pharmacies at the state level.
Thank you.
Thank you. Representative Carter.
Thank you, Mr. Chair. As an honorary Uper, I have to say that, I kind of want to piggyback off of Rep. Tisdale's question. I did a little research and I found only 3 FQHCs in the UP. Can you tell me how many are up there? The UP is vast and has already hospital challenges getting across the Upper Peninsula. Can you verify how many FQHCs are up there and how eliminating this barrier of contract pharmacies would help the people in the Upper Peninsula?
Sure. So I believe there's 2 Indian health organizations that are members, and then 1 federally qualified health center, Upper Great Lakes Health Center, which covers roughly half to 2/3 of the Upper Peninsula. Yes, it would make a huge difference to that health center because I think they cover a square mileage of like 6,300 miles, and they get to pick 1 contract pharmacy. What they use many of their 340B dollars for is to supplement OB care. And as many may know, that is something that is in high demand in the Upper Peninsula and in short supply. So those are the types of things that are in jeopardy. And it's not just the UP, it's Northern Michigan, it's the Thumb area. Many of these health centers have large service areas, and so the restrictions on contract pharmacies are quite severe.
Thank you.
Thank you, Representative. Seeing no further questions, I appreciate you guys coming back this week. I'm glad we didn't try to squeeze it in 5 minutes last week. It would never have worked. So thank you very much for being here. We appreciate it. Next up, we have another brief testimony on 340B. We'll be joined by Kathy Lewis and Leslie Baldwin from Michigan Rare Coalition, along with Bill Stone, I'm assuming, that most of us know. Welcome, Bill. Thank you. The testimony table is yours. When you guys get ready to speak, just make sure the mic is on. And thank you again for your time today.
Thank you, Chair Vanderwall, and thank you, members of the committee. My name is Bill Stone. I'm here today with Leslie Baldwin and Kathy Lewis with the Michigan Rare Coalition. It's a new group, so I apologize if you couldn't find much info on them from a Google search, but they'll explain what they're all about and offer their thoughts. So I just wanted to thank you in advance for your time, and I'll turn it over to Leslie.
Okay. Thank you. Thank you so much for having us this morning. Good morning, Chair Vanderwall and Vice Chair Thompson and the distinguished members of this committee. My name is Leslie Baldwin. I grew up here on the west side of Lansing. I went to Waverly Schools. My dad worked for the state while I was growing up, and I really have to say I really admire everyone putting their efforts into public service. It really makes a difference, so thank you. I am representing here today Michigan Rare Coalition, but I am also a rare disease patient. Michigan Rare Coalition is newly launched. In fact, so new that we're still working on launching our website. So, but we're local here. I live in Holt. And it's a 501c3 advocacy organization dedicated to improving the lives of Michiganders affected by rare conditions through advocacy, education, and collaboration. A rare disease is a condition that affects fewer than 200,000 Americans. There are 10,000 identified rare diseases that in total affect about 30 million people living here in the United States. And in Michigan, we have approximately 1 million residents who are living with a rare disease. So if you look around in your families and your neighbors and your communities, there are plenty of people with rare diseases out there that deserve a voice, and that's what we're here to provide. The creation of the 340B drug pricing program was intended to help hospitals afford the rising cost of medications, including as the Primary Care Physicians Association came up. We appreciate all of it. I think it's a fantastic program. Manufacturers provide steep discounts for outpatient medicines to 340B safety net clinics, qualifying hospitals, and pharmacies. Hospital, clinic, and pharmacies participating in the program are expected to pass on the savings from the discounted drug program to vulnerable patients, which includes rare disease patients, as well as low-income and underserved communities. In theory, this should increase affordability and patient access to needed medications. And I think we can all agree that drug prices are high. However, I think, it's a very complex system in the country right now for manufacturers, for the healthcare system, and looking at how we can really work together to save patients money. While I commend the efforts of the 340B program entities in Michigan, current reporting requirements do not provide the information fully needed to assess how they are passing on 340B program savings to low-income and vulnerable communities. As of 2025, there were 87 Michigan hospitals participating in the 340B program. The national average for all hospitals providing community charity care, free or low cost, was 2.5% of a hospital's total operating costs. The 340B program hospitals in Michigan, however, averaged only 0.09% of that total as earmarked for charity and low-income assistance. 97% of Michigan hospitals participating in the 340B program fell below the national average of 2.5% for charity giving of total operating costs allocated for community charity care. The 340B program legislation, what we would like to see in representing the rare community, while it does and should provide protections for hospitals, for the entities themselves. We agree wholeheartedly that they should have protections, but we feel currently we have not been invited to the table before today to address the perspective and needs of vulnerable patients and communities. So we're looking at what are the protections, what are the cost savings, and efforts to address access issues. I think we heard some good examples this morning, which is fantastic. But I think some of the data that's available isn't necessarily as helpful in terms of, where populations, breaking down the population, who are you helping exactly? You might be working in an underserved area, but what does that mean? So what we're, proposing or would like to at least put out there is to include the patient and community perspective when looking at 340B reform legislation, requiring hospitals to provide a detailed report, and I realize they do have a lot of administrative burdens. I worked at Texas Children's Hospital in Houston, Texas for a number of years, and was administrator of several programs. And so I know what administrative burden looks like. So my thought is I don't want to add undue, but I do think we need to take a common sense approach to looking at what is the data that is going to be really helpful to know that the savings are going to those who need it most. Requiring 340B entities to include rare disease patients as part of their population in low-income, underserved areas, wherever they have facilities, would be great if we knew what that data was. And require data reporting from 340B program entities that accurately reflects how they are directly benefiting their communities by breaking down, who they are actually serving would be extremely helpful. The other challenge, which was noted already, are the contract pharmacies. Many of the contract pharmacies with the 340B program are here in Michigan, but there are over 1,000 that are not in state. Access to their medications is a real problem for our community. And as we see more pharmacies closing, I think we need to be looking at, are the pharmacies able to participate that are in the communities that need it most? So in closing, I want to thank you for the opportunity to speak on behalf of Michigan Rare Coalition, and I appreciate all your time and efforts today. And if you have any questions, I'll be happy to try to answer them.
Good morning, Chair Vanderwall, honorable members, distinguished colleagues, and respected constituents. My name is Kathy Lewis. I am a Special Projects Director at the Amyloidosis Foundation, a co-founder at Michigan Rare Coalition, a rare disease patient, and a mother of a daughter who has a rare disease. I stand before you today to discuss a crucial issue impacting some of our most vulnerable citizens, those living with rare diseases. The 340B drug pricing program plays a vital role in providing these patients with the necessary care and financial support that they need to survive and thrive. The 340B program was designed to help safety net providers, such as hospitals and clinics, stretch their resources to serve underserved populations, including rare disease patients. Many of the treatments these patients require are really expensive and involve specialized care, making the financial relief offered by the 340B crucial for their well-being. However, we are seeing a troubling trend. Hospitals are not passing savings from the 340B onto patients. Instead, they charge full price for medications while profiting from the discounts that they receive. Proposed reform fails to address the real issue, the patient perspective. They do not ensure that rare disease patients will benefit from these savings that the hospitals receive. Rare disease patients face unique challenges, such as traveling long distances for specialized care. There's very few centers of excellence, and there's not even one in every state. So this already adds to their already high medical costs. To better support them, we should consider establishing charity care programs within hospitals, allowing patients to access necessary care and medications without financial hardships. Many rare disease medications have no generic alternatives, like Leslie stated, and it makes access to these costly treatments even more critical. While the 340B program has the potential to help by providing discounts, this system is broken. Hospitals claim to offer charity care, but for many patients, this help is difficult to access, and financial toxicity remains a significant barrier. Another critical issue is transparency. Hospitals are not required to disclose how they use the 340B savings, leaving patients unaware of how these discounts are even being utilized. We must demand transparency and accountability. Policymakers should require hospitals to report how those 340B savings directly benefit rare disease patients. It's time for reforms that prioritize patients, not hospital profits. Michigan must implement reforms that include mandating hospitals to report patient savings from 340B, ensuring 340B covered drugs are accessible at community pharmacies, and prioritizing rare disease patients in these program benefits. Rare disease patients and advocates have shared their stories, and our voices matter. We stand with them in this fight for justice. Thank you.
Thank you. Committee, any questions? Representative Carter.
Thank you again, Mr. Chair. I really appreciate you bringing the points that you brought forward. It's not isolated to just your, no. In fact, one of the biggest oppositions I've had has been from the A. Philip Randolph Institute, which is a national organization saying the exact same thing. But I do understand the fact and the need to have these facilities, these FQHCs available and accessible, and I brought that up in my previous testimony about what's going on in the Upper Peninsula. So my question to you would be, if you had that magic wand, okay, and I hear what you're saying patient-driven. The patients, the people who benefits from the program is the one that needs to have a seat at the table. So if you had a magic wand where you could craft legislation that would solve your problem as well as help out the hospitals to do their job, what would that be? Just curious.
Okay. Thank you so much for that question, Representative Carter. I really believe that and strongly believe in my work and nonprofit work over the last 40 years, that it's important that everyone has a seat at the table where we can openly discuss. So that would be hospitals that are participating, clinics with community leaders, I think, need to have an understanding of what the effect is for the 340B program, and as well as the drug manufacturers. So I think, really getting the different stakeholder perspectives, but it's so vital. It always astounds me that how many times the patient perspective, and, of course, we're here representing rare diseases, but anybody with a chronic illness, with cancer, that has encountered challenges with access or affordability issues should be really represented at the table as well. We should be keeping their voice in mind, and, really talking about where are the challenges. We heard from the hospital, from the clinics talking about the administrative burden, and I certainly understand that. What can we do to streamline it? What can we do with manufacturers coming to the table also, as well as insurance companies? Because many of us are very restricted over what pharmacies we can go to. I can't tell you how many times it's taken several weeks to get all of, when I've had to switch to a new pharmacy because of insurance, going to a specialty pharmacy, and then you've got to, they've got to get everything going. You need your prior authorization. So it's not medication that a physician is prescribing and then, the patient gets it. It's a whole process. And so I think we really need to look at, are we meeting the needs of our communities, and are we meeting the needs of individual patients? I hope they answered it a little bit, but I think coming to the table and having some real conversations about reform would be wonderful.
Follow-up, quick one? Okay. And it did, because I feel that if we're going to craft legislation, it should involve all the stakeholders' viewpoints. I've heard some very good testimony from both sides, but the most important side is who's going to be the end user, who truly benefits from the 340B program. So that's just something I see, a little thought. Thank you, Mr. Chair.
Thank you.
Thank you. Any other questions? Yes, Representative Thompson.
Hi, just one real quick question. Thank you so much for coming and testifying. Congratulations on your new startup. Just out of curiosity, because you are a new organization, how do you guys receive your funding?
Currently, we have zero funding. We are, we are self-funding it. We're co-founders. We're working with a group of advocates here in Michigan that either have some relationship to the rare disease community, some have their own organizations, but we really felt it was important to do what we could to support the community. So I like to say that we are willing to work with anybody who would like to work with us to improve patient care, to improve access and affordability.
And one follow-up, if I may, Chair. Currently, right now, rare disease in the state of Michigan, where are these patients receiving their care?
I didn't hear that.
Typically, rare disease patients, depending on how rare it is, may have to travel long distances. Major academic centers, Michigan State, some patients might be receiving specialty care there, certainly through the University of Michigan health system. You know, for myself, I think at one point I had 10 different specialists spread throughout the state because I couldn't find one facility that really, you know, was able to handle, you know, the needs that I had. There was no center of excellence for some of what I'm dealing with here in Michigan, so I've had to even go out of state for care.
Are those specialty clinics designated and allowed to use the funding, the federal funding?
Yes, they are.
Okay. All right, thank you.
Very good. Seeing no other questions, thank you all for being here. I appreciate it. And we look forward to continuing more discussions on 340B. Before we close out today, is there anybody from Pharma or the Hospital Association that wanted to speak? All right. If not, Representative Frisbee moves to excuse absent members. There being no objection, the motion prevailed by unanimous consent. There being no further business before the Committee of Health Policy, we stand adjourned.